صباح الخير عليكم جميعا. Thank you Dr. Rashad for the introduction. أنا اسمي وسيلة طه، ولي الشرف إن أنا أكون board member لإيفلا. إيفلا stands for Egypt Africa Venous Lymphatic Association، وممبر في EVAS Egyptian Vascular Endovascular Summit. I have no disclosure, and this is a photo raised 20 years ago, where it all begins at the Sahel Teaching Hospital. Duplex ultrasound is a dynamic diagnostic tool that delivers detailed images of varicose veins. الحقيقة ده مش slide scientific، ده quiz. How many D's in this paragraph؟ واللي هيعرف how many D's دي this packet of chocolate. How many D's؟ بسرعة. غلط. 7. برافو. مين قال 7؟ يقف. برافو. الأجندة طويلة، فاحنا هنحاول نخلينا نجري بسرعة على قد ما نقدر. هو this is the core of the matter that all the refluxes are not the same, and we have to detect the different sources of refluxes. For the guidelines, either the European or the American guideline, they highly recommend that the duplex ultrasound will be the first modality to diagnose or to set the diagnosis of venous insufficiency. As all we know, the SEER classification, and I hope that you know also that there is a new revised SEER classification with the recurrent varicose vein, corona phlebectica, and the recurrent venous ulcers. About the new nomenclature, I think احنا عندنا كلنا حاجات كده bogus information about the new names. هي ما بقتش new anymore لأنها it starts from 2002 by Alberto Cacciati, and I had the honor to meet him in person. And this is احنا بنستعمل كتير قوي long stiffness وجريتر وشورت ولسر وخصوصا superficial femoral vein. كل الكلام ده obsolete. احنا لازم نستعمل common language, the great stiffness, small stiffness. And very importantly, there is no anymore the word superficial in front of the femoral vein, because as all we know that it is a potentially lethal misnomer. So when we talk only femoral vein and not anymore the superficial femoral vein. But we see still in our reports, unfortunately, the old names. مهم قوي examination. حتى لو انت بتشتغل بس ultrasound، مهم قوي انت تعمل examination. مهم ازاي how to report و extract كل الديتيلز المهمه اللي هتساعدك على البلان of treatment والمابينج. دولت التو بروبز المهمين اللي احنا بنستعملهم. اللينير ده هو ده المين تول بتاعك في الدايجنوزس whenever you are يعني dealing with the venous or arterial أو even for the carotid. الconvex mainly for the IVC, for the iliac veins, aorta and iliac arteries. هنا ده السكاننج. هنشوف طبعا بالتفصيل كل ده في الهاندز اون. To assess the patency by compressibility, the very compressible great stiffness vein, and to assess the reflux, which is the core of the matter, you have to be on longitudinal scanning, and this depends on the Doppler equation where there is a cosine of theta, so you have to have your descending Doppler on angle less than 60 degrees. This is a typical of significant prolonged reflux. This is two extremes, no reflux and significant prolonged reflux. What is the threshold? The threshold is by the duration, and it is 0.5 second duration when we are talking about the superficial venous system. It is very easy. هنشوف برضه في الهاندز on how to assess الريفلكس و how to measure the reflux in duration. ساعات بيبقى عندنا ولا احنا مش عارفين نقول ده reflux ولا no reflux. Like in this example. فهو برضه one more time the beauty of the machine بتطلع لك انه objective measurement هنا 0.36, so it's not a significant reflux. The sources of refluxes الحقيقة very important to tackle each one, and this is the key of slides. We have numerous and plentiful sources of reflux وهنعدي عليهم one by one. برضو one more time the anatomy based on duplex برضو based على الكونسنسس بتاع 2002 by Alberto Cacciati. وهو فرق جدا. It was a turning point or a breakthrough لأن قبل الكونسنسس ده ما كانش حد بيبقى عارف مين الجريت stiffness مين المين تريبيوتري. فالجملة اللي هي جوه الكادر الأحمر ده this is very important statement. The main stiffness trunk in the facial compartment. لما تلاقي مهما تلاقي tributary enlarged, dilated, a very big tributary, this is a tributary because it's not lying inside the facial compartment. Inside the facial compartment, this is what we call the saphenous eye. The cross-sectional great saphenous vein inside the facial compartment between the superficial fascia and the deep fascia. طبعا احنا عارفين كلنا ان هم مسمينها كمان Egyptian eye لانها it looks like Horus eye. نيجي للسمول سافنس فين لانه برضه عنده anatomical variations كتيره قوي. احنا عارفين ازاي how to detect it وبرضه inside the facial compartment، بس هو very often يعني 65% بيخش جوه البوبليتيال vein، but sometimes it enters below even the popliteal vein. It enters into the gastrocnemius veins or extend كفالات what we call thigh extension. مش بس كده، sometimes في بدل thigh extension يبيرس superficial fascia ويتيرن posteromedial to join the great saphenous vein. في الجزء ده بالذات بنسميه Giacomini vein أو intersaphenous vein. This is very important to know about the anatomy based on duplex. طب هل كل ده الستوري بتاعتنا او the only source of reflux الجريت saphenous والسمول saphenous؟ in fact no. عندنا حاجات كتير قوي منها الاكسسوري ترانك. هنعدي على الاكسسوري ترانك لان اهم واحد فيهم الانتيريور saphenous vein. It's not anymore accessory وهنعرف ليه. وما اعرفش اذا كان حضراتكم حضرتوا معانا الويبينار one of the advanced phlebology كان 16 نوفمبر we tackled this subject الانتيريور saphenous vein. الحقيقه هو ترانك ولا تريبيوتري؟ تفتكروا ايه وليه؟ الانتيريور اللي احنا كنا مسمينه زمان accessory saphenous vein هو ترانك. دي thanks to ماريان دو مايسنير، هي البرنسبل اوثر بتاعت اليوروبيان جايد لاينز، قالت ان هو ترانك based on the statement اللي احنا اتفقنا عليه ان هو inside the facial compartment. One more time, it's very important to now use the word anterior saphenous vein and not anterior accessory saphenous vein. Inside the facial compartment يبقى زي الجريت saphenous. اللي هنفرقه ازاي؟ Don't be confused. ده anterior like its name number one. Number two, it's aligned with the femoral vessels. مع الاس اف اي مع الفيمورال فين هتلاقيهم في نفس الالاينمنت. الجريت سافنس نيفر ايفر هتلاقي الصوره دي. مش بس كده، الترمينيشن بتاعته بتبقى in between the inguinal lymph nodes. مش بس كده، الكورس بتاعه بيبقى very short. It's not like the great saphenous vein. هنا هنتعرض على الكورس بتاع الانتيريور saphenous vein. ممكن قوي يبقى very very short less than 10 سنتيمتر، بس in very vast majority of the patient احنا بنشوف هنا في البراكتيكال باك جراوند بنلاقي the vast majority هو الموديل نمرة 3 اللي هو short enough بس كمان at mid thigh level. وفي الحالات الريكارنس بتبقى communicating with superficial varicosities. أهميته إيه؟ أهميته علشان الريكارنس ريت كتير قوي بنشوف الريكارنس caused because the anterior saphenous vein. دولت different sources of refluxes من الجراين، فمهم قوي ان احنا نديتكت الانتيريور saphenous vein. هل هو ده كل ده الستوري الجريت saphenous small saphenous anterior saphenous vein؟ in fact no. في حد tributary مهم قوي superficial accessory saphenous vein. لو شفنا الشيماتيك دايجرام وكورسبوندنج الالتراساوند بتاعه هتلاقي one circle inside the facial compartment. This is the king. This is the great saphenous vein. But here we have two circles. We have one inside and one very superficial outside the facial compartment. This is superficial accessory saphenous vein. The third one, it's even much more interesting. We have the great there is no great saphenous vein, so the facial compartment is voided from any vein. And the only vein here is the superficial accessory saphenous vein, and it's very superficial just under the skin. Very important on a practical, we have here the great saphenous vein, a pinpoint inside the facial compartment, while all the reflux and all the pathology comes from the superficial accessory saphenous vein with a prolonged and significant reflux. This is the whole story? In fact, no. We have a superficial varicosities, and this is our butter and bread. A young lady comes in your clinic with bunches of superficial varicosities and she wants to get rid of مني. عندنا سيناريوهات كثيرة قوي. المهم الثلاثة سيناريوز دول. These bunches of superficial varicose veins, they are related to the great saphenous vein. أو الجريت saphenous vein هو refluxing in presence of these superficial varicosities. ده scenario one. Or just superficial varicosities and the great saphenous vein is competent. There is no problem. Or another third scenario that has nothing to do with the territory of the saphenous trunks, what we call the non-saphenous or the atypical varicose vein. So this is the small saphenous vein with no reflux or no the facial defect, no communication between the small saphenous and the extraaxial varicose vein. Here the great saphenous, he has a communication with the extraaxial varicose vein and with a reflux derived from such bunches. طب بنعالجهم ازاي دول؟ احنا عندنا تو ثيوريز مهمين. يمكن كل الجروبات، لو انتوا في جروبات انترناشونال هتلاقوا كلود فرانشيسكي كل شويه يحط لك شيفا تكنيك شيفا تكنيك. شيفا تكنيك بتقول ايه؟ بتقول انه it's very crucial the role of duplex ultrasound to see انه الريفلكس هو السورس of venous hypertension, and it is derived from the deep system to superficial, the main superficial, and then from the superficial the great saphenous to the extra axial or the superficial. فانت دورك كاوبريتور في الدوبلكس انك تعرف the level which level انك to abolish the reflux on the great saphenous vein just to tackle the superficial varicose. It's very important, and what we call the descending theory. The concept here is to preserve the great saphenous vein. Another technique, but it's a the concept is here also to preserve the great saphenous vein, but the theory, it's totally different. It's the ascending, and we have the privilege to host Paul Pitaluga وسيلفان شاستانيل هم mentors of this as well technique, برضو to preserve and to tackle only the superficial varicose vein, but here the varix itself is the start of the venous hypertension, but not the shunts or the closed circuit. This is the whole story. In fact, we have the incompetent perforator, and I would like here to assess the pathological incompetent perforator and not the re-entry perforator. There is certain criteria by duplex. I hope all of us we are familiar with this. The facial defect should be larger than 3 millimeter, bidirectional flow of the color flow when you do distal manual compression and release, and the duration of the reflux longer than 0.5 seconds. This is the whole story. In fact, now we have the vicinity of the ulcer in such a devastating patients with the venous leg ulcers. We can see the bunches of peri-ulcer veins, or what we call ulcer veins, and this is very important to tackle this source of venous hypertension, and we are honored to have this publication in March 2025, a few months ago, in GVS, lymphatic, venous and lymphatic disorders. And this is by EVLA group with the multinational study. A lot of universities and teaching hospitals, they are contributing in this, with the Imperial College, with Professor Alan Davis and Professor Joseph Shalhoub. This is some examples. It was an randomized and arm with foam sclerotherapy, ultrasound-guided foam sclerotherapy, versus with standard treatment, versus instead treatment, and we found a faster healing for the ulcer healing time in the first group with ultrasound-guided foam sclerotherapy. This is the whole story. In fact, no, there is the non-saphenous, while the leaking point, or coming via leaking points, superficial varicoses of the lower limbs from the pelvic leaking point. They are not typical. We call it non-saphenous because they are not really at the journey or the course of the saphenous trunk, either the GSV or the SSV, mainly the gluteal or the sciatic varicose veins, or the posterolateral, but sometimes also the perineal, and sometimes also in the vulvar region. And we will have very interesting cases in the segment of the cases discussion. Here, very important to see the terminal and the pre-terminal valves, and from where the reflux of the pelvic through the superficial epigastric vein comes. Listening to our patients is very important. So here a patient, she has restless leg, pain. You screen the great saphenous vein, you screen the small saphenous vein, there is no reflux. No, not at all. But on screening of the posterior aspect of the thigh, there is a lot of varicosities, non-saphenous varicosities, and what we call the sciatic varicose vein. And her pain comes from here. Over the 2 days, as mentioned by Dr. Rashan, Dr. Ayman Samir, we will have the opportunity, the great opportunity to see all the new modalities of the modern vein therapy, from the laser, from the glue, the RF, foam sclerotherapy, and I hope you indulge a lot over these 2 days. Which is the best modality? What do you think? Laser, RF, foam, glue, which is the best modality? In fact, this is a wrong question. And the good question, who is the best candidate for every modality? And this is the beauty of the duplex ultrasound. If you master the ultrasound, you will answer this question very correctly and very accurately. And you sum up all your data on a schematic map, like here. And to conclude, a schematic map with reflux patterns, it's very important unquestionably, and it is a good objective plan بيلم لك كل السورسز of refluxes. It's a good technical success of the procedures. You assume good long-term results and you assume less recurrent. And this is a very recent photo just 1 year ago. And I invite all of you to get the privilege for Unite for Science, the 3S. Unite for Science, the Stress and Synergy, and the coming events 29th October till 1st of November. And thank you so much for the invitation.